Um, and now I want to welcome you to the CBITs monthly digital mental health webinar. And this is the last the last session for this academic year, and we will be starting again in September. The lineup for September will be posted on our website in the next few days. But today, to close out this year, I am really pleased to have Lisa Marsch with us. Lisa is the Andrew G. Wallace Professor of Psychiatry and the Director of the Dartmouth Center for Technology and Behavioral Health. And Lisa will talk a little bit about the center at the end of her talk, but it integrates multiple disciplines across Dartmouth, including from the schools of medicine, arts and sciences, and engineering, and works in the development, evaluation, and sustainable implementation of technology-based tools for behavior change. Lisa has worked in a lot of different areas in behavior change, including mental health, HIV, pain, eating disorders, but her work in the treatment and prevention of substance abuse has really been where I think her work has been most pioneering and most impactful. She has a very large portfolio of research funding, primarily from NIDA, and I won't go through it all, but she has a P30 Center grant from NIDA and directs the Northeast node for the National Drug Abuse Clinical Trials Network. So Lisa's going to be talking with us for around 45 minutes or so, and then there will be time for questions. If you have questions, please just enter them into the Q&A, and then we'll read them off at the end of the talk. So thank you very much, and Lisa, welcome.
Great. Well, thank you so much, David. Thank you for this invitation to join you all today. It's terrific to be part of this outstanding group of colleagues, and I always follow the excellent pioneering work of your center, and congratulations on your recent P50 grant. Looking forward so much to our discussion today. I'm going to go ahead and share my screen.
Yeah.
And hopefully you can see my slides now. Great. Thank you. So it's really an honor to be here and to wrap up this season of your seminar series. And as you heard from David, I'm going to be talking specifically about the role of digital therapeutics in the treatment of substance use disorders. And I wanted to mention that in addition to my academic affiliation at Dartmouth College, I have affiliation with a few small businesses that are involved in developing and deploying various digital health tools. And then additionally wanted to surely acknowledge the funding that we've received for some of the work I'll mention today from the National Institutes of Health, including our center grant from the National Institute on Drug Abuse, as well as some support from the National Institute on Mental Health. So the theme of this talk is specifically on the application of digital health to substance use disorders. And we know that substance use disorders are really quite significant issues in many pockets of the world. And as one example, in the US, we know that about 1 in 13 individuals aged 12 years and older has a substance use disorder. It's about 21 million persons in the US. And I know we have some international folks joining us today as well. And as folks may know, in recent years in the US, we've had a very significant issue with drug overdose, primarily from opioids. And it still remains the leading cause of death of Americans under age 50, drug overdoses. And, you know, it's actually higher than deaths from car crashes, higher than deaths from HIV, higher than deaths from gun violence. So it's a very significant issue. And unfortunately, in the recent past, in the last couple of years, in addition to the opioid crisis we've seen in the US, we've also seen a surge in stimulant use, particularly methamphetamine and cocaine use in many pockets of the country, often along with opioid use. And we've also seen increases in vaping. And then just as you all have seen in the work you do in the mental health space, we've also seen that during the global pandemic, we've seen a marked increase that's been documented in alcohol and other types of substance use during the COVID-19 pandemic. We know that there are indeed life-saving treatments that exist for the treatment of substance use disorders, but we also know that most people, as high as 90% of people with substance use disorders, do not go to treatment for their substance use disorder. Many reasons why this is the case. It includes stigma associated with care in certain settings, although fortunately care is increasing, access to care is increasing in many diverse and growing array of settings, but stigma is still an issue in seeking care for many individuals. In many communities, care is still inaccessible, particularly rural settings. There might be long waiting lists to get into treatment. We know, and this is especially true with the recent increase we've seen in substance use disorders during the opioid and polysubstance use crisis, that we don't have a sufficient addiction workforce to meet population level needs. And then we also know that when people actually go to care, the quality of what they get in treatment is variable, and it might not be reflective of the state of the science, and people might not get best practices or gold standard treatments. So it's really a time of great need with the opioid crisis, with the polysubstance use crisis, with the intersection of these trends with the global pandemic and the extensive harm caused by this confluence of factors. So there's a lot of attention being paid to this, the unprecedented need that we're seeing, but also the really great opportunity that we have to think about scalable solutions. How can we really reach at a population level the scope of this need? And so this is where digital therapeutics, we think, can play a role. And I know that you all know this space very well. And we think about digital therapeutics really as part of a much broader multi-pronged approach to tackling the substance use crisis, but really are excited by the data and by the promise we see with the data and the application of these tools to scale up access and promote widespread access to effective resources, including digital treatments for substance use disorders. So I'll just be very brief in the background on this, given the expertise of this audience, but I'll start by talking about sort of what are digital therapeutics. So when we think about digital technology, like mobile technology, for example, this has just markedly changed our society, how we do education, how we do finance and retail and social communications, and how we have conferences these days. And so the work we do is really on the intersection of harnessing the growing ubiquity of digital technologies to really think about how can we transform our understanding of health and healthcare delivery. And digital therapeutics in particular is a term that refers to medical software, so clinical grade software that is effective in the prevention, treatment, or management of a disease or disorder. So this is not referring to simple wellness apps or health promotion types of apps, but it's really taking the active ingredients of a therapeutic process and embedding it in the content and functionality of a digital treatment. So this is an intensive sort of, behavioral treatment, for example, like cognitive behavioral therapy, or a treatment that might promote medical regimen adherence, and delivering it in a seamless digital delivery platform. And I'll give you some specific examples of this in the realm of substance use disorders. So just briefly, the promise of this is that by offering digital treatments, these medical interventions via software, we can extend the reach and impact of clinicians. It's like another tool in the toolbox of clinicians they can make available to their patients. It can kind of supercharge the clinician workforce and extend their reach and impact. It's kind of like a clinician in your pocket. And actually, there's now a very large literature that you all may know quite well that has shown that digital therapeutics, if developed well and really reflecting best practices, can greatly improve patient outcomes for many types of patient populations. We can ensure fidelity to best practices in the way that these tools can deliver care. And virtually any population across the globe that you can think of, even some traditionally underserved or vulnerable populations, either have or are expected to get access to mobile technology. Not everyone has it now, but all the trends are going in the same direction to suggest that people are increasingly getting access to mobile devices and connectivity. So the promise here is that these are scalable ways to provide science-based care anytime and anywhere. And of course, the promise here might be more timely than ever, given the increased demand for remote models of care that we've seen during the global pandemic. So there's a pretty large literature now for folks who may not be aware of it in the realm specifically of the application of digital therapeutics for substance use disorders. It's well over probably close to 2.5 decades of research, perhaps even 3 at this point. And this slide kind of gives you a snapshot of the state of the science of the application of digital therapeutics to substance use disorders. And so the big picture of the literature shows that if these digital therapeutics are developed well, developed in collaboration with the target audience, actually have utility and engagement with the target audience, we can see that they are highly useful and acceptable to diverse audiences. They can have a really robust and replicable impact on many types of health behavior and health outcomes. We've now seen in multiple studies that digital treatments can produce outcomes that are as good as or sometimes better than clinician-delivered care. And as you all may, see in the work you do, sometimes people bristle at that and say, "Are you trying to replace me with software?" But really, what we need to understand is it's really important to demonstrate there are active ingredients in these tools that really can exert effects and help enhance clinical outcomes and help increase the reach of our limited clinician workforce, and do so in a way that can be effective. And indeed, we've seen that you can increase quality, reach, and personalization of care. They can be cost effective. And I think it's very exciting that they don't always have to work the same way every time. They can be adaptive. They can be responsive to people's changing needs and clinical status and clinical trajectory over time. So I'm going to give you one example of a digital treatment that we had the opportunity to develop the research version of a couple of decades ago, and it's been studied in many, many NIH-funded trials. And it's just an exemplar. There are multiple effective, empirically supported treatments for substance use disorder that are delivered via software. And I'll give you a link where you can go and explore others if you'd like. But I just want to highlight one example here to show you how a digital treatment can help with substance use disorder treatment, and then what kinds of outcomes you can see when you implement this in different models of implementation. So just briefly, this is an intensive behavioral treatment that is based on a very empirically supported behavioral therapy approach called the community reinforcement approach to substance use disorder treatment. And this is a pretty intensive behavioral therapy. So it's got like 60 some components to this digital intervention. And it really takes this gold standard therapeutic approach and delivers it on a digital platform. And it's focused on understanding and disrupting harmful behaviors and harmful cognitions, and that lead to self-defeating patterns of drug-taking behavior, and really give people new skills and tools that they can apply in their daily lives to disrupt those patterns, to change that self-defeating pattern of drug use, and in doing so, leveraging various personal, social, vocational resources to help people change problematic drug use. So in addition to this intensive sort of skills training and sort of the tools embedded in this intervention, there's also another component that sometimes people have used as part of the digital treatment and sometimes not. It's an optional component that basically employs contingency management, which is basically where you give people incentives, those are sometimes called motivational incentives or rewards for achieving gains in their treatment process. So for example, sometimes people can get rewards when they engage in therapy sessions. Sometimes they can get rewards when they provide urine samples that show that they're negative for their problematic substances. And this is a way to help people get sort of incentivized to initiate and maintain gains in changes in drug-taking behavior. So all of that is automated and delivered in the digital platform. So this is just a few screenshots from this behavioral treatment. Again, I'm not going to go into this into a lot of detail. I'm happy to talk about it more, but the goal is just to show you this is an example of a medical intervention that's delivered on software. So now I'm going to show you some data that gives you a flavor of the kinds of patterns of outcomes we have seen when applying this digital intervention in different models of implementation. And I'll start with one of the really early studies that was done with adults diagnosed with an opioid use disorder, entering outpatient treatment for opioid use disorder. So every single participant in this trial received medication called buprenorphine medication, which helps stabilize the brain neurochemistry of someone with an opioid use disorder. Everybody got the medication, and they were randomized into one of 3 conditions, which reflected different types of behavioral treatment. So if you were randomized into the arm that's reflected here in the blue column, you were randomly assigned to meet with a clinician 3 times a week in individual counseling sessions. And this clinician was trained to deliver with fidelity this effective, gold standard community reinforcement approach to behavior therapy. If you were randomized to go into what's reflected in the red column, you had a clinician, you checked in with that clinician every other week, but the bulk of your therapeutic intervention was delivered on the digital platform. So this digital version of the community reinforcement approach to behavioral therapy. Both of these two groups also received incentives contingent on drug negative urine results. And then both of these interventions were compared to what's reflected here in the gray bar, which is at the time was reflective of what constituted standard behavioral therapy at outpatient treatment programs for treatment of opioid use disorder in the US, which was not based on the community reinforcement approach. And so basically what you see from this one snapshot, we have lots of data from all of these studies, but I'm just giving you a flavor of the data. What we see is that even when you offload the bulk of this therapeutic approach to a digital platform, you get comparable clinical outcomes to those observed from exclusively clinician-delivered care. And both of those produce outcomes that are significantly better than standard treatment. So let me show you a different model of implementation and outcomes we saw in this trial. This was done again with adults with opioid use disorder entering outpatient treatment. Everybody in this particular study received medication. In this case, it was methadone medication that people received daily. And then they were randomly assigned to either receive standard methadone treatment, which is called the treatment as usual condition, where they receive daily methadone medication and also the kind of counseling available to them in a methadone treatment program. Or they went into this condition, which is reflected in the blue column, where they received their medication offered daily, but also they had the opportunity to access the digital treatment as part of care. And the way we did it in this trial is instead of meeting with their clinician, let's say for 60 minutes, their clinician-patient contact time was cut in half and replaced with the digital treatment. So they would meet with the therapist for 30 minutes, and then for the other 30 minutes, they would interact individually with this digital intervention. And we found that when we cut in half patient-clinician contact time and replace the other half with this interactive version of this effective behavioral treatment, that we had much greater weeks of opioid negative urine samples. So much better outcomes in terms of reducing opioid use when people got the digital treatment as part of care versus they did not. So again, we're delivering in an interactive way with fidelity, this gold standard treatment in this setting. And we see when we do so, we markedly enhance patients' outcomes. This is all measured via objective urinalysis toxicology data. I just wanted to comment, and I'll be curious if you all are seeing this in the work you do in the realm of mental health, but one thing we've seen in this study, as well as many studies now, is that digital therapeutics aren't contraindicated for any particular population of folks with substance use disorders, but we see the biggest effects often among people who have particularly high risk profiles when they enter treatment. So in this particular study that I just described, people coming into treatment who had low cognitive functioning at baseline, or high anxiety at baseline, or not so motivated for treatment, high ambivalence about treatment, or co-occurring heavy alcohol use, or people who had been cycling in and out the door of addiction treatment programs and had greater number of prior treatment episodes. All of those individuals with those profiles at baseline had among the greatest benefit when they got the digital therapeutic as part of treatment versus when they did not. And we've seen that now in multiple trials that digital therapeutics might be useful in minimizing some of the impact of these specific risk factors, which actually usually are, often predicting poorer outcomes in treatment. So I just wanted to give you a brief overview of a study that tried to disentangle the relative utility of the two components of this therapeutic intervention. As I mentioned, there's an intensive skills training component. There's also this motivational incentives component. And this was a trial trying to see if the skills training component added anything over and above the incentives. We know contingency management works. We know it's really the best standard treatment for treatment of stimulant use disorders. And this is incredibly important now because we don't have any medications that are approved for the treatment of stimulant use disorders. But the question here was, is that driving all the effects, or when we add all of this intensive skills training on top of these incentives, does it add anything? So this was a 2-arm study where adults in outpatient treatment for opioid use disorder with medication population either received the contingency management alone, the incentives alone as part of treatment on this digital platform, or the combination of contingency management with a full community reinforcement approach to skills training. And we found when you add the combination together, we had markedly higher retention in substance use treatment versus the contingency management alone. So really this combination has been shown to be key. And actually I should just highlight that even in the non-digital version of this intervention, the combination of this community reinforcement therapeutic approach plus the incentives really are considered gold standard treatment for particularly stimulant use disorders. And then a couple more examples of implementation approaches and the kinds of outcomes you see with this. This was a study where people entering outpatient treatment, we didn't change the underlying model of care in any way. We just said, what if we just give you a mobile version of this digital treatment as part of your care model when you walk in the door into treatment? How does it impact outcomes? So this was a study where people either came into standard treatment, they received medication on an outpatient basis, or they came into treatment, they received standard treatment plus access to a mobile version of this digital therapeutic. So we just give them access to this tool as part of treatment. And we saw when we gave people access to this tool as part of treatment, we kept people in treatment longer. So we had markedly higher retention in treatment when you give people the tool as part of care versus when you don't. And here we're looking at the first 3 months of a treatment episode. So when people walk in the door, what did retention look like in the first 3 months? We know that treatment retention is an incredibly important predictor of longer term positive outcomes in substance use disorder treatment. So keeping people retained in treatment, particularly in this key window early on in treatment, is really quite important. We saw the same pattern emerge when we looked at drug use. So this is looking at urine toxicology data, showing opioid abstinence data. We saw when you give people the mobile tool as part of treatment, we had higher rates of abstinence from opioids versus when the tool is not part of treatment. These are just snapshots of data and studies, but the kinds of patterns I'm talking about here, we've seen this now in a much larger literature. And then one final data slide that I'd like to highlight that shows yet a different model of implementation. This was a really large multi-site study conducted on NIDA's National Drug Abuse Treatment Clinical Trials Network platform. It's a really large network across the US that can run the same study protocol in multiple diverse pockets of the country at the same time. So you really get to tap into diversity in your sample. So this was done across multiple states, and it was with a very diverse array of polysubstance users entering outpatient treatment for their substance use disorders. So folks with stimulant use disorders, cannabis, alcohol, lots of polydrug use in there. And there are lots of papers and data from this study, but I'll just highlight this key data slide. And let me walk you through what's reflected here. So the top two lines are the subset of participants who, at the time they joined the study, already had been able to provide a urine sample negative for their problematic drug. Okay, so they had some abstinence under their belt at the time that they're starting this trial. And we see for that group who had some more stability when they joined the trial, when you get the digital treatment as part of care, which is the top line here, there was a very, very slight advantage in terms of increased abstinence rates for that group versus those who weren't using when they joined the trial and didn't get the digital treatment as part of care. But the bigger, more robust effect was observed here. These two lines at the bottom reflect people who are actively using when they entered the study. When those folks actively using received the digital therapeutic as part of treatment, which is this line here, we see they had a much bigger effect in abstinence rates from their problematic substances compared to this group at the bottom, which were actively using when they started the study and did not get the digital treatment as part of care. So there's still a lot of room for improvement here, but you see this is almost a doubling of abstinence rates and in some of these time points when you get the treatment, when you get the digital treatment versus when you don't. And then we also saw similarly, when you get the digital treatment, we had an advantage in terms of retention in treatment versus when you don't, as we've seen in multiple studies now. So I'm sure you all know this well, but if you don't, it may be of interest to you to know that in the US now, there's a new category of medical devices that can be prescribed that are called prescription digital therapeutics. So when the US receives data from clinical trials from a digital therapeutic and evaluates it for safety and efficacy and says, yes, indeed, this has been shown to be effective in the prevention, treatment, or management of a disease or disorder, it can get this prescription digital therapeutic status. And what that means is that providers can prescribe software. And so this is a remarkable new development. The first FDA authorized prescription digital therapeutic in the US was based on the last data slide from the therapeutic education system that I presented to you. It was approved in September of 2017. It's now morphed into a different mobile product. The core content of it is the same, but now it's renamed, and there's a company that has been deploying this. And then a second iteration of this intervention was FDA authorized in December 2018, specifically with an indication for the treatment of opioid use disorder. But as you all likely know, there's been a large surge in not only sort of data being presented to FDA for consideration for prescription digital therapeutics, but we also saw that the criteria for getting the authorization were lessened somewhat during the COVID pandemic, particularly for digital treatments around mental health to increase their accessibility. And we've seen a big surge, particularly in the year and a half, in what's available in this space. So I mention this because, I think that this is undoubtedly a key part of how we envision the future of healthcare and the key role that digital health tools can play as part of care models. And particularly to get this authorization, as you may know, it needs to be considered a type of medical device, needs to be software-driven, evidence-based, and make a claim. So you're actually seeking a claim to say, our data suggests that this is effective in preventing, managing, or treating a medical disease or disorder. And so it excludes general wellness apps. And one thing we've seen, I think there are multiple paths to accessing and deploying these tools, but one benefit we've seen of this particular FDA regulatory pathway is that we've had healthcare providers come to us for many, many years saying, I'm really excited about digital treatments. I want to make them available to my patients, but there are thousands and thousands of apps in the App Store. There are 200 new wellness apps popping up every day. What do I recommend to my patients? What are the best ones? How do I navigate this space to know what to recommend? So one benefit of this is that it might help providers understand at least, which of these apps have been vetted and gone through this careful review process at the FDA level. But again, there are multiple paths to accessing this. This is just one path that is evolving rapidly. So if you all have interest in learning more about clinically validated digital therapeutics for substance use disorders, we have lots of resources on our center website, including a program review where we have snapshots of the various digital treatments that are available for treating substance use disorders. And again, I just wanted to highlight one example for you here today, but there are a growing array of effective treatments available. So I think what we've seen and what I'm excited about in this space is that, we've now had the opportunity to do research in this space for many decades, and the data are very compelling that these interventions can provide effective and accessible treatments, can provide science-based treatments. There are growing models of access. Yes, we don't have CMS reimbursement yet nationally on these models, but there's an active dialogue at the state level in many states. We also know that increasingly, in addition to the prescription model that I mentioned, there are a number of pharmacy benefit managers that are building digital health formularies, including Express Scripts and including CVS Caremark, and growing the array of digital treatments that they are making available to their clients, as well as a growing array of employers in this space. So there's a lot of activity, not just in the US, but in many pockets of the world. And there are some countries, including Germany and the UK, that are pretty routinely providing financial coverage for these digital treatments as part of healthcare models. So I think it's a very timely and significant opportunity right now to think about how to scale these and sustain them in a way that really can transcend population. I'm talking here today about substance using populations, but you all have seen in your work how useful these tools can be with many diverse populations, and that can be really a generalizable solution in providing healthcare resources in many settings. So in the spirit of scaling, I'm going to give you one example of a study we've been doing that's focused exactly on that. It's around how do you scale up science-based mental health and substance use care with digital health. And this is a project that we've been doing in partnership, mostly with colleagues in Colombia, but also with partnering countries of Chile and Peru. And just briefly, as you likely know, Colombia has it's a country with a very long history of armed conflict. And, we had the FARC peace agreement probably about 5 or 6 years ago, but multiple generations in Colombia have been touched by this armed conflict and all over the country. And so there's very high burden of mental health problems, including high rates of depression, high rates of heavy alcohol use, accompanied often by domestic violence. And so when you have this very large population level need, but very limited mental health workforce, and in this case, often confined to urban settings like Bogota, how do you meet the population level need at scale? And so that's the question we were trying to tackle. And we were trying to do so by centrally leveraging digital health approaches to enhance and expand the impact of the existing workforce to really reach across the country. So this is a partnership with many partners, not just our team at Dartmouth, but Javeriana University in Colombia and the National Institute of Mental Health, many healthcare systems across the whole country, many governmental organizations, including the Ministry of Health in the region, many national patient organizations, the payers in the region, and many non-governmental and multilateral organizations, including the World Health Organization, the Pan American Health Organization, and the World Bank. And so the goal here is that we're trying for the first time in primary care systems across the country to encourage people for the first time to screen for depression, for the first time to screen for alcohol use, and then to provide care in that context for these conditions. And so digital technology is embedded along the whole pathway. So there is some provider training where primary care providers are trained for the first time to understand what these conditions are and to embrace them as part of their care models, but there's an automated, all of the screening and all of the diagnosis is all done using clinically validated assessments done on a digital platform. When the provider is presented with a patient who meets criteria for one of these or both of these problems, they have a clinical decision support tool that walks them through with this patient in front of them what might be best practices in treatment. And then every single patient gets access to a digital therapeutic platform so they can have access to effective treatments in the privacy of their own home on digital platforms. And so here is how it works. There are kiosks. Folks, the programs want a kiosk in the waiting room where people can go and answer some screening questions that then can lead to more extensive diagnostic evaluation. The clinicians here, you can see a screen here where the clinicians can see for a given patient information about their risk profile and can be guided through care models, effective care models, so that they're really having resources to help ensure that they're wedded to best practices and what they're doing with the patient. And then the patient, again, is getting access to a digital therapeutic that's been developed based on a couple of decades of NIH-supported research that we've been engaged in that embraces a lot of the active therapeutic tools for behavior change, particularly in this case for depression and reducing unhealthy alcohol use. And so this is an ongoing project. We started with a pilot study of 50 patients. We've now screened 17,000 people. In Colombia, it continues to be an ongoing project. So we went from screening 0 people in primary care in the country for these problems to, now continuing to screen and provide treatment to people in those settings. And we're heavily looking at outcomes, and there's a big commitment at the government level to sustaining these models in primary care. But and for the sake of time, I'm not going to go into all the granular data that we've gotten thus far, but it's an example of an effort to try to think about how can we scale models of digital health and embed them sort of in the business model and the clinical workflow of a healthcare setting to expand capacity. So I've been talking thus far in the presentation about digital therapeutics and how digital technology can provide therapeutic resources. But as we know quite well, digital technologies can also allow us to measure people's behavior and understand people's behavior in new ways and collect rich information about people's health and their environment and their behavior in naturalistic settings as they live their daily lives. And can also, if we can really capture this in a very rich way, allow us to provide personalized interventions and resources based on people's needs and preferences. And so, we and others, and I know you all are working in this space as well, have been seeking to understand how digital technologies like mobile devices, like wearable devices, can help us assess people's behavior, that we can apply rich analytic approaches to those types of intensive longitudinal data gathered in people's daily lives to understand people's clinical trajectory and to predict and respond to changing needs over time. So this is a space of digital health measurement, and sometimes people are calling this digital biomarkers. The idea is that, it's a very early stage in the realm of substance use disorders, but it really looking at, can these types of digital data capture allow us to capture information about people's behavior and health in a way that might help us better understand people's clinical status and its evolution over time, and the confluence of factors that might impact people's behavior in the moment. And so it's about sort of this digital data capture to understand the full range of human behavior in an environmental and neurodevelopmental context. So one term that we see in this space is called digital phenotyping, and that's often referred to as the moment-by-moment quantification of individual level data on mobile devices. It could be that through ecological momentary assessment, where we prompt people to respond to brief queries on their mobile devices. It could be through passive sensing. There's extraordinary computational capacity on smartphones and on wearables like smartwatches, even smart jewelry, that can really allow us to capture a lot of information about people in their daily lives. And so not only might it give us more insight into a sort of a contextually informed understanding of human behavior and particularly people in recovery from substance use disorders, but if we can really refine our predictive models well enough, it might let us know what someone might need right now in the moment and trigger a digital therapeutic intervention in the moment that's responsive to that need. So there's a growing but small literature in the realm of substance use disorders on digital biomarkers. I'll just give you a sort of a flavor for what we're seeing in this space. So for example, there's a group of folks that have been looking a lot at people who are smokers trying to quit, and showing a pretty nuanced understanding of lapse events, lapses to smoking, and how they have been shown to be associated with increases in negative mood for many days and not just hours before a smoking lapse event. So, information we might not get from sort of just our standard clinical assessments we do in an episodic way, let's say in a healthcare setting, but really trying to get more insight into the intersection of these variables in naturalistic settings. There's also a group at NIDA's Intramural Research Center that's been looking a lot at this, and they've started to illuminate some interesting relationships between craving and drug-taking behavior and stress and drug-taking behavior. And one example is that craving has been shown to be predictive of imminent drug use, but self-reported stress has been shown to be much less predictive than craving of imminent drug use. And so they're really trying to disentangle some of the interrelations among these risk factors in drug taking. And also there's a growing literature showing that some of the contextual factors that people in recovery experience might differentially affect use of different types of substances. And so, for example, there's a research showing that drug triggers, things like being exposed to drug cues, mood changes that might be a risk factor for a given individual, have been shown to increase for hours before cocaine use events, but not before heroin use events. So interesting sort of interrelations that are being revealed in terms of the digital biomarker space, but then also some early and growing research, including work at our center on developing personalized interventions based on this ongoing digital assessment. So here are a few examples just to give you a flavor of this literature. When we are studying people who are seeking to quit smoking, and we're measuring in real time their smoking risk, when we give tailored messages that are responsive to a people's level of risk, like in the moment they're advised to chew a piece of nicotine gum, we've seen that's more engaging and effective than usual care. We've also seen that when you're monitoring things like people's nicotine withdrawal symptoms or their real-time medication side effects, that providing then adaptively tailored advice in response to that data has been shown to be more acceptable among smokers seeking to quit versus usual care. And then we've been engaged in an initiative through the NIH Science of Behavior Change initiative that's looking at different populations. And we've seen that digital interventions that can impact elements of momentary self-regulation, things like momentary emotion regulation, momentary perseverance, has been shown to impact health behavior that day or the next day across different populations, including heavy smokers, including people with binge eating disorders. And we're also doing a study now funded by NIDA's Clinical Trials Network, which is digital phenotyping of adults in outpatient medication treatment for opioid use disorder. So it's very exploratory. We're recruiting adults in outpatient treatment, and they're all receiving buprenorphine medication. This is in partnership with Kaiser Permanente. And we are asking them to not only allow us to capture passive sensing information from smartwatches and their smartphones, but we're also asking them if we can extract their social media data and also ask them to respond to queries we prompt them to answer on mobile devices. And the idea here is that, we know that medication treatment for opioid use disorder is literally life-saving. We know, though, that sometimes people relapse, sometimes people drop out of treatment, sometimes people don't take their medication, and we have some clinical understanding of why that's the case. But the idea here is to see, are there data that would help us get new insights into what confluence of factors might today predict I'm not going to take my medication, or might today predict that I'm going to use heroin? And so that's what we're seeking to understand with this project. What data might be most useful in predicting these relations? Where is there redundancy across data sources? And really trying to see if we can build some predictive models with these data captured in a naturalistic setting to help us better understand these really clinically meaningful events. So we get lots of data from sensors. There's all kinds of features you can extract, not only from smartphones and smartwatches that allow us to make inferences about people's sleep and behavior patterns and heart rate and sociability, but also lots of information we prompt them to answer about their stress levels, their pain, their craving, their withdrawal, their actual substance use behavior, their momentary self-regulation, their actual medication taking, and then lots of information we can extract from social media about content that's posted, about images, about topology of social network and its change over time. And that's where we finished recruitment. We're doing the analyses now. And so stay tuned about this. What we're excited about and why NIDA was funding this is that, they're interested in knowing, are there subsets of these data that could be useful to complement the typical kinds of outcomes data we include in clinical trials? So in addition to the, monthly data or weekly data we get that's very standardized on these clinically validated assessments, could we complement that and extend our understanding of people's clinical status with some subset of this digital data? But then ultimately, if we really can get these models right, and we're not quite there yet, but if we can, the idea is that this might really help us understand when to trigger an intervention in the moment, ideally at the right time in response to people's needs. So in conclusion, I think that this field of digital health measurement, I think the promise ranges from discovery science to translational science. So in the discovery realm, really looking at the opportunity for this digital data capture to help us understand, are there digital biomarkers that might be meaningful, to clinical outcomes, are there outcome measures that are digitally derived that might be meaningful, but then also, can this impact the translational spectrum where we provide personalized interventions that are responsive to the dynamic nature of behavior? I think the field is promising, but I think it's kind of a proof of concept right now, where there's a lot of promising studies out there, but we don't have very good validation of measures in this space yet, at least in the substance use realm. We don't have lots of rigorous trials with control groups, and we surely don't yet have reproducibility of results. So lots of opportunity here. If people are interested in this, you could build a whole career path on this. I'm just going to take a couple of minutes so we have some time for questions and discussion to give you a little snapshot of our center. This is our Center for Technology and Behavioral Health. And we are heavily focused on using science to inform the development, evaluation, and sustainable implementation of digital health tools, including heavily digital therapeutics for treatment of substance use disorders and related issues. We're housed at Dartmouth, but we have partners not only all over the Dartmouth community, but across the US, and several international partnerships, and very interdisciplinary group. You see the realm of expertise we've got across our partners. Really, truly, as I'm sure you all have experienced as well, this interdisciplinary expertise is really key to the breadth of work that we do from across the whole translational spectrum, from basic science work to lots of experimental research to implementation efforts, and really to understanding how to scale the most science-based practices to impact people's lives. And so I'll just end with a snapshot of some of our current research directions. These are our new priority research directions at our Center for Technology and Behavioral Health. We've been focusing a lot on transdiagnostic digital therapeutics, not just having digital tools that do one thing or have a siloed focus on one disorder or health domain, but really embracing the intersection of co-occurring conditions, not just mental health and substance use, but also various physical health conditions, and having tools that can be responsive to that array or that sort of profile. We've been growing our work in adaptive digital therapeutics, which I spoke about briefly. We are very keen to expand our work in the realm of digital health ethics. This is a hugely important area, and I think there's a tremendous opportunity to grow our dialogue and best practices, not only in research, but in real-world deployment efforts around this topic. We have some new partnerships to increase training in digital health among underrepresented minority scholars, and then another initiative that's really focused on scaling best practices and with partners in the scientific, clinical, industry, and governmental areas to really help inform how to scale access to science-based digital therapeutics globally. So not only what's happening in sort of the marketplace that might drive some of the scientific questions that are important for us to ask, but also to ensure that the most potent, most science-based interventions are understood by payers and by in the industry in industry. So in conclusion, we're very excited about the opportunity for digital health. I surely don't think it is the solution to all of our challenges in the healthcare arena, but the data are very compelling that it can be a very important, effective part of models of care. I think that we've seen the utility of this approach across populations, and that as we grow more in the digital sort of assessment space, the opportunity to better craft precision medicine and even precision prevention approaches for a wide array of populations. I think one day in the future, we're not even going to talk about digital health as its own thing. It'll just be embedded into the fabric of health and healthcare, and will be part of sort of the routine models of care that we offer. So I will stop there. So we have about 11 minutes, as I see, for questions and discussion. We have a very active social media presence at our center. If you all are interested, we encourage you to follow us. Here's our Facebook and Twitter information. So thank you so much. I'll stop sharing and look forward to your feedback.
Hi, that was outstanding. Thank you so much. And we have a lot of great questions coming through. So I'll read some out. So first was around the interventions when you were showing the collection of data over several trials, which was really exciting to see. And the question is, since these interventions are typically added on top of standard care, the intervention patients are getting a higher total dose. Is this simply a dose effect?
Yeah, it's a great question. Thank you for the question. So actually, in some of the early trials, I didn't point this out so much in my talk today, but in some of the early trials, we set them up to be parallel groups designed to control for that very thing. So for example, in the very first study that I described, when we said, okay, you largely get this intervention through a digital platform versus through a clinician versus standard care, we actually held constant the dose of exposure to the digital intervention so that it was comparable to the dose of exposure to the clinician delivered version of that. And so, yes, we put some artificial constraints on access, because one of the beautiful things about digital treatments is that you can access them anytime and anywhere, and that might be particularly useful clinically, but we wanted to control for that in the research studies. And so we ensured dose of exposure was comparable. And so the outcomes I showed there, the outcomes I showed in the methadone treatment study, actually in probably all but one of the studies, the one where it was a mobile version, all of them had this parallel groups design and held that constant. So thank you for the question. So yes, we saw those results in that context, but I do think that the on-demand access and the availability, 24/7 actually is a huge strength and can further increase the potency of this and the accessibility.
Awesome. The second question is somewhat related, but how many of these interventions require a working phone data plan? This, of course, plagues a lot of us. How do we deal with patients who can't afford a full month of data to avoid worsening health inequities?
This is such an important question, and it's a very significant issue. I mean, as we spoke about, we know that growth, access to mobile devices, even access to connectivity has been growing exponentially in many parts of the world, but it's not ubiquitous. We know that a lot of people don't have smartphones. They have other types of devices. They may not have real-time internet connection, and this is not just true in low and middle income countries. This is true in our country. This is often true in rural New Hampshire, where we are at Dartmouth College, and so I think that. Fortunately, access is growing, even connectivity and infrastructure around that, but it's not perfect. And I think this underscores the importance of developing tools that can provide rich therapeutic resources despite challenges in access. So what can we develop that can reside locally on mobile devices that might be meaningful to an individual that doesn't require real-time connectivity to the internet? Maybe you can connect when you do have connectivity to push updates and pull data and things like that. But what can we provide to people on devices they may have, I think is very important. And in fact, I didn't mention this, but this is something we've been talking about, having more of a concerted research and development effort around in our group to tackle, equities. That's not the only solution. I think that there are many significant issues there. I'd love to brainstorm with your group on this as well, because I know you have some great people working in this space as well.
If I could just actually ask my own follow-up. So what would be an example of one that you could see as being sort of available, accessible, where you wouldn't need to be connected? Like in substance use, what could be a good resource?
So if you're looking for a particular name of a tool right now that works that way.
Or even an example, like I like how you described the intervention component. What would be one?
I think that you could have, tools that reside on the local device that literally can apply to you in your daily life. Like, what if you're Saturday night and you're craving and you're at risk of relapse? What can you have right there locally that can be on your phone that can help you navigate that situation successfully? And so the tools and some of the skills training components, you can develop those to reside locally. And so, and you can even rely on, and I know David's been doing a lot of work in other countries too, where you have to rely on sort of other type, like platforms like texting communications or other types of communications or resource delivery that doesn't require sort of, real-time access to the internet and all of the extraordinary computational capacity of smartphones. Because you can, of course, accelerate and enhance the scope of what you do in that way. But I think it's a meaningful question. How do you, and I think it's understudied in terms of a rigorous line of research that's really focused on how do you optimally produce, deliver potent, meaningful, engaging interventions in a way that can circumvent some of these challenges that you're highlighting in disparity populations and settings.
Thank you. The next question, I realize it comes like, rapid fire, but there's a lot of good ones coming through. What are some examples of motivation rewards?
Oh, okay. So there are multiple examples of this. Sometimes people get access to sort of goods and services that might be like a gift card, for example. In the platform that I spoke about, that's now a mobile sort of prescription digital therapeutic, people actually, contingent on, let's say, negative urine samples, can get gift cards to like Walmart or Starbucks or other settings. I don't actually know the full array of settings, but they can get sort of credits and earnings of that have monetary value that can be used in different settings like that. Those are some examples. In a lot of studies, people have actually given directly, cash incentives, but in the digital therapeutic platform right now, it's largely gift cards, as far as I know. There may be other examples, but that's what I've seen. Yeah.
Cool. Okay, I'm going to jump over here. Do you see prescription digital therapeutics as the primary means for scaling digital solutions in mental health? Comment on payment and value proposition for all stakeholders.
Yeah, it's such a good question. I think that I know there are a lot of people that do think it's the primary and should be the primary because it allows for this very careful, rigorous review and vetting process to get that status. so I think there's a lot of value in that. But if you look in the industry sector, a lot of companies are kind of doing things not unlike what the FDA is doing. They're doing their own vetting. They're saying, you know, we're looking at the landscape of what's out there, and we're making decisions about what we're going to put on our own digital health formulary and make available to our client base. And so there are parallel processes that don't always include this governmental regulatory pathway. And I think that, you know, a lot of this is still early stage within the last couple of years, and I don't know that we fully understand, you know, the relative utility of each model or the combined benefit of having multiple diverse paths to deployment. And then again, other countries have sort of national payment models, and you know, and are making decisions about what will be covered there. So I think it's a great question, and we're seeing a growing array of options in this space. And actually, I think that's one of the things that's appealing about it, is having flexible models of, you know, deployment, and not necessarily wedding access to a prescription, right? But saying, you know, we know, you all know this, people with substance use or mental health problems, it's only a small sliver of those populations that actually go to treatment. So how can we have ways of accessing that huge subset of those populations that aren't going to treatment, aren't accessing treatment, aren't getting prescriptions for these treatments? And so how can we direct to consumer, for example, and other paths provide access to these effective treatments, I think is an important area of focus.
The opening, wonderful presentation. Can you speak to the opportunities and potential challenges from using novel hybrid AI approaches to diagnosis and monitoring of substance use disorder and other disorders? Here, the novel hybrid AI is meant to mean including behavioral economic, cognitive science features for standard data-driven classification. Thank you, Hans.
Yeah, it's a great question. Thank you, Hans. Yeah, so I think this is, you know, part of the growing literature and research we're seeing, not just in the scientific community, but in industry sector as well, and really trying to understand how well these AI approaches can really monitor and diagnose, and how well the models can, you know, predict, you know, if today someone is going to relapse, or if today someone's going to have a psychotic episode, or whatever the event of interest is. I think that there's a lot of excitement in this space. There's a lot of funding going into this space. I think there's a lot of promise. I think the models are not precise yet for many health domains. And as I mentioned earlier, I think we need to see how well we can reproduce and show rigor in this space, and have reproducibility in this realm. I think though a lot of people are going to work on this, and are working on this, and that we will, I mean, I've definitely seen very promising data in this realm thus far, but I think that, you know, people are also very intolerant of false positives. So if you say, I think right now someone might be in need of an intervention, and you trigger something to them, and your data are wrong, and that wasn't the right timing to deliver it, people only tolerate that for a certain period of time, and then they're not going to engage with your intervention, you know, for a long period of time. So I think we really have to have sort of good clarity on these models to really meaningfully trigger momentary interventions based on it.
We're right at time. There's one more question, if you may have a minute. For those that do have to hop off, we had a question about sending the PowerPoint, and this is being recorded, so you can access this on our CBITs website in just a few days. So that's great. But the last one is that someone had joined a bit late. And so Lisa, if you did have a minute, but no problem if you have to run.
Yeah, sure.
Have you looked at acceptability of using these tools across racial, ethnic demographics? And if so, what did you find? And I recall you did talk about, you know, retention and some of the acceptability type measures, but I may have missed it too. So yeah, I would ask that last one.
Well, thank you for the question. So right now we have a big team of people in our center that have undertaken this very ambitious effort, which is way more ambitious than we had planned, to do a full sort of scoping review of the literature to understand the breadth of what's out there for various racial, ethnic backgrounds in the digital therapeutic space. What do we see in terms of sort of customized approaches and how that impacts outcome, or other sort of trials where they've looked at sort of subgroup outcomes and subpopulation outcomes, but where are the gaps as well, and what are the opportunities? And it's actually a larger literature than I had thought, and part of it's going to be presented briefly at the College on Problems of Drug Dependence conference, if folks go to that in a couple of weeks. But stay tuned for the paper, because we're really trying to get a lot of data to empirically inform the state of the science now, because I think there's tremendous need and opportunity in this space. So whoever asked the question, if that's of interest to you, feel free to get in touch with us, because I think there's a lot of research opportunities there.
Thank you.
All right. Well, thank you, Lisa, for really a fabulous talk. It's always wonderful to catch up on the really the enormous amount of work that you and your center do. So thank you. And I want to thank everybody for attending. As I said, this is the last talk of this academic year. We'll be starting again in September. So our lineup next academic year will start with Nick Allen, who'll be talking about digital mental health in youth. Munmun Dechaudry, who will be talking about social media, and Ricardo Araya, who'll be talking about global digital mental health. So again, thank you, Lisa. And
my pleasure. Thank you so much for the opportunity. It was great to connect with you all.
Thank you.
bye-bye.
There. Bye-bye.